And it's really with a great pleasure that I introduce this next panel. We're going to start our conversation today, and what we'll do is have each panel presenter talk for about 5 minutes from their perspective of the priorities from their area of expertise. And you'll see, based on what we talked about earlier, that we're looking at our Asian American population, our African American population, our Native American population, and Hispanic and Latino. So you'll hear each of those perspectives. Then we're going to open up for questions from the audience, and some questions that we've pre-assigned for our discussion. So first of all, we're going to start with Captain Clelland, and I'm very pleased that he can be joining us from CDC. He is the director of the Office of Tribal Affairs and Strategic Planning. So, Captain, if I can have you start for us this morning. Thank you.
Certainly appreciate the opportunity to be here, to be a part of this discussion group. It looks like a great panel. As I was thinking about this topic, which is the cultural component of how we interact and engage, and then what is that impact on cardiovascular disease or cardiovascular outcomes, I was thinking about recent experience. So unfortunately, I'm at that age, 55, I was kidding, where you have to get more tests and more exams and things like that, especially on cardiovascular health and supporting, at least longevity, hopefully, as well as making sure I'm able to continue to do things that I want to do. So as I was thinking about this topic, I was thinking about my recent experience with regards to, needing to go for a physical and being able to present to my physicians that were going to be doing the various tests on me. One of the things that I did, and I don't know if people that work with American Indians or Alaska Natives really have the opportunity to delve into, is that before I decided to go do all these exams and tests, I decided to go see a medicine woman that I normally go see. And the medicine woman is in Arizona. So I took the time off to go out there and find the medicine woman that I normally go to see. Unfortunately, she's no longer seeing people now because she's at an age where she can't do what she did. So I don't know if you know much about American Indian, Alaska Native medicine people, practitioners, but they play a key role in the health and wellness of American Indians and Alaska Natives. So I ended up spending some time, came back to Atlanta, I spent some more time in trying to find, she was specifically a crystal gazer. So I tried to reach out to find a different crystal gazer, one that didn't know me because I'd been going to her for years. And I ended up finding another crystal gazer. So I put off my tests and my exams and things like that and went out again to go meet with this crystal gazer medicine woman to be able to get a sense of where I'm at, where am I at within my health care, as well as what things would she be able to identify that I could then relay to my practitioners that I would be going to see within the Western medicine component versus traditional medicine through my for American Indians. So I went to the crystal gazer and did prayers and she did her practicing with regards to the impact that she was going to have on my health, as well as getting to know me and getting to know, what is my role and, how does that fit in and how is my role also impacting my health. And it was very good interaction and the ability to continue to tie that in, because if I hadn't found another crystal gazer, I probably would have done the medical tests anyway, but then I felt like I would have not been complete in my patient experience, my overall patient experience, which is tying in that cultural component, which in my case was to go to see a medicine person, as well as making sure that it identified with what I needed to do to support my own health, including my own heart health, and being able to make sure that that was an advantage for me in my role as well as in my work that I was doing with regards to my current activities. So American Indians and Alaska Natives have a large cultural influence in the way they interact and engage. It's not a one-all-fit-all size, as with many of the communities that we've talked about, and they'll probably talk about here, because there are 573 American Indian and Alaska Native tribes within the United States. Doesn't mean that they're all different, and they may have similarities, but there is enough uniqueness there that it's important to understand those cultural references and reflections that are going to be able to impact their health, especially looking at the number one cause of death in American Indians is cardiovascular disease, as it is with many of the other minorities, but also how are practitioners engaging in the ability to understand some of those influences that might impact their decisions to be adherent, to be able to understand, and also how to incorporate that into their own social well-being, where it makes these areas like cardiovascular health and disease and prevention in order to help support them in their overall lifestyle. So that's something to think about as we engage in conversations with patients, as well as being able to support them in their ongoing health.
Great, thank you for getting us started and sharing that personal perspective too. So next we're going to turn to Dr. Kevin Thomas. Dr. Thomas is joining us from Duke University. He's a professor of medicine, and so we're very pleased for making yet another trip to DC to help us learn a little bit more. Thank you.
So thank you very much, and good afternoon. So it's truly a pleasure to join you all today to talk about a topic that I think is of extreme importance. And really it's an urgent situation that we have to take upon us and really deal with and elevate to the highest priority as we think about medical research and healthcare reform, this issue of health disparities, and trying to understand as we live in a society where the population is changing, and it's changing very rapidly. And so those individuals who previously were known as minorities or underrepresented individuals are now becoming the majority. We have to ask ourselves, are we prepared for that? How comfortable are we with understanding the issues around receiving health care, accessing health care for all of these populations? And so some of the work that I do at Duke University is I'm a electrophysiologist, which is a fancy way of saying I take care of people who have electrical problems of the heart. But I'm also a researcher, and I've committed my research career to really understanding, not just describing that there's inequitable treatment and there's healthcare disparities and differences that exist, but really moving beyond that to understand what is the genesis and the reasons that are contributing to this, and arguably more importantly is how can we begin to think about interventions and strategies that will address and hopefully ameliorate these differences and disparities in healthcare delivery and outcomes that we see. So I spend a lot of time. Durham is a burgeoning community with a really significant admixture of different cultures and race and ethnicities. And so currently we're about 60% African American, about 20% Hispanic and Latino. It's a really rapidly growing community in Durham. And so again, I spend time trying to understand, are we prepared as a healthcare system to deliver care to these patients and the relevant constituencies that are changing? And so I think in my experiences, what I've begun to appreciate, and as my research has grown and developed over the years, is that people fundamentally make very different decisions that are driven by a lot of societal circumstances, deep cultural traditions, and things that have been passed around for generations that supersede, I think, the obvious. So obviously people think about access and people think about socioeconomic status. But a lot of these differences and disparities that we see really go beyond that. Certainly those play a role, but they're not the full story. And so we begin to understand this process of decision-making, health literacy, and what type of influences are helping people with their health care. So just going to the doctor. I can tell you from my own experience, I grew up middle class, lower middle class, and we had health insurance, but we just simply didn't go to the doctor. It was not part of my parents' experience growing up. They lived in rural areas in Virginia, and it just wasn't something that was to the forefront of what we thought about. Now, if you got a significant injury or you've been sick maybe for 2 weeks, you might go to the doctor, but it just wasn't something that was normally part of our cultural experience and something that we did regularly. And so I think things that we have to think about that are really important is, and I'm a big proponent of patient empowerment. And I was really struck by the story that we heard earlier by Charlene and her experiences. And the thing that really jumped out to me, I think was really humbling, and also let me know that I think we're on the right path here, is that, you know, she was empowered to ask for more. I think oftentimes when you're a part of a vulnerable population, you feel like, you know, you're not entitled to ask questions or to push back and do things when you feel like things aren't going the way you want. And so I think what's really important and incumbent upon us and for organizations like the Alliance is to really push patient empowerment. We want people to be educated. We want people to feel like they have a voice. If they meet with a provider or a clinician and that individual is using a language that they don't understand, just stop them and say, hey, you know, I appreciate your educational background. I'm an educated person as well, but in a different kind of way. You know, speak to me in a language that I understand and that I can appreciate. And sometimes people aren't doing it because it's intentional or they're trying to make you feel bad. They're doing what's normal and comfortable to them, and sometimes that comes across in a very different way. I think the other thing that's really important is that we have to empower patients and individuals to really be educated and to do their research before they come to their providers. I can tell you that healthcare is changing, and not necessarily in a good way. So we are being asked to do more with less. We have less time to see patients. We have constant issues with electronic health records, documenting things. And so providers are doing the best they can, but they're being asked to do 3 times more in less time. And as healthcare becomes more complicated, there's more things to discuss, more things to share. It's a challenge. And so I really encourage my patients to be advocates for themselves, but also to be record keepers for themselves, because, you know, they're the person who knows what's going on. A lot of times patients will come see me and say, well, you know, you can just read that in my chart. I'm like, you'd be surprised that half the stuff in your chart's actually inaccurate. And so the one person who knows the truth is you. And so treat your health like you treat your checkbook. You know, hopefully you're not going to be out there writing checks and not accounting for those, but treat your health the same way. And I encourage my patients to come, bring a notebook with them or an iPad or whatever they choose to use, whatever is their preference. And as we have a discussion, to take notes. If I start a new medication, I'm going to explain to you why. I want you to write that down so that as your list of medications, hopefully it doesn't grow, but if it does grow, you are educated and you know why you're taking something, when it was started. And so I think we need to move beyond a lot of this notion of that the providers are all knowing and omnipotent and they make all the decisions, to really empowering patients to take back their own health care, which I think is extremely important. And so I look to talk more deeply about this and to, again, talk about how these relationships can be improved, how we, those of us who are healthcare professionals or clinicians, can be better at sharing information, articulating risk. I think these are all areas for improvement and things that I know I'm passionate about and try to learn about and study in my own research. So thank you for this opportunity to participate, and I look forward to where this will go moving forward.
Great, thank you very much, Dr. So next we're going to hear from Dr. Veronica Vitale. She's a professor of nursing at the University of Arizona, and also pleased to note that she's a member of our steering committee and for the Alliance on Minority Health. So thank you, Veronica.
Good afternoon. Is this louder? Okay. Good afternoon. It's an honor to be here. And I just wanted to share with you that I'm part of the Hispanic Nurses Association, the National Association of Hispanic Nurses. And we represent 6% of all nurses, Hispanic nurses. And so there are very few of us. And so really important to address the disparities. Our organization is out there in the community addressing the needs of our communities. So we have over 50 chapters across the nation, and all of the chapters are in our community. We're doing the grassroots efforts, and we're trying to bring all of the concerns and barriers forward so that we can address them. And so it's an honor to be here, to be the voice of our communities. So as we've learned, the Latino community, there's many subcultures of the Latino culture. And so the cultural context of these individuals is actually going to influence their ability or how proactive, it'll determine how proactive they'll be in their health care. And we have to really understand that there is no, as my colleagues have mentioned, that there is no cookie cutter approach, that we can't take a cookie cutter approach to healthcare for the Latino community, because there are some similarities across cultures, but then there are also some differences there. So we have to address those differences as well. So there is some diversity in these cultures. As we learn also that social determinants of health, such as socioeconomic status, income, education, and social mobility will all influence how engaged an individual will be with their health care. Also, immigration status with the Latino community. The immigration status is one determinant if they will engage in healthcare. Many of the individuals who are not, don't have a legal status here fear going out and getting their healthcare. And so that's a big challenge for the community. Some of the barriers that the Latinos experience are access to healthcare, affordability. Some have a hard time understanding the insurance, if they do have insurance, how co-pays work. And so some of them have had insurance for the first time. And how do we utilize insurance? Many Latinos, we don't believe in preventative care, or I don't want to say we don't believe, but we don't go seek preventative care. A lot of us wait until we're emergent, and then we're in the emergency rooms and seeking care that way. Also, equity of resources. There's a challenge in that because there could be resources that are available, but are they truly culturally competent and addressing the needs of the community? So the other issue is health literacy. Some Latinos struggle to navigate the healthcare system because of the health literacy that they have. So another thing with Latinos and healthcare is the trust issue. With some Latinos, we would prefer healthcare from an individual that looks like us. You know, we really would like someone to understand our culture and be able to identify with us when it comes to healthcare. So unfortunately, we're in the process. We're trying to have providers mirror our communities, but as we know, as I mentioned, Hispanic nurses only represent 6% of all nurses out there, so we're a far ways from mirroring our communities out there. And also, since we are short of providers that are Latinos, then our hope is that the providers out there are culturally competent. We would be hopeful that they are aware of the differences across cultures and that they show respect. And it's important to really include the family, familismo, and engage the family that's there with them in their offices for their visits. And so our goal as Latino providers is to really empower our patients to take more control of their health and to be able to be informed of their health care. And then also the ultimate goal is to reduce the health disparities that we do see in the Latino community. So thank you. Thank you.
Thank you. Again, another important perspective.
Thank you, Veronica. That's very interesting statistics. I wonder what's the percentage of Latino physicians there are? Probably a lot less. Yeah, I would say it's a lot less than 6% even. Thank you so much. First of all, I want to thank Darlene for sharing her story. It was a powerful story, and I'm so proud of the work that Women Heart is doing. For women out there. I wear red every day to represent the campaign to increase awareness about heart disease in women. And I'm going to start my talk about the dangers of lumping diseases, looking at population statistics and epidemiology. When we look at statistics, it always says that heart disease is the #1 killer, cancer is second, and in the 1970s, when they started looking at statistics in the population, they found that there were more men dying of heart disease than women. So what did we do? We took care of the men. Well, heart disease was also the #1 killer of women, but we didn't take care of the women. And so what happened was the men got statins to lower their cholesterol, and women got HRT. Well, by the year 2000, there were 70,000 more women dying of heart disease than men. And that's the danger when we use statistics and population statistics and epidemiology to treat people. The same thing was happening in Asians, and I'm representing the Asians. 2 billion, more than 2 billion people in the world. So it's a lot of people, and they're not all the same. And that was the thing that we needed to really look into when it comes to taking care of Asians. Because when you look at the population, African Americans were high risk, the whites were high risk, the Latinos were high risk, and the Asians were not. Within that Asian group, there were 6 major Asian subgroups, including the East Asian and the non-East Asian. So the East Asians are Chinese, Japanese, and Koreans. And they tend to have lower risk of heart disease than the other groups. But South Asians, Filipinos, which is what I am, and Vietnamese people are high risk for heart disease. It's just that when you're in the United States and looking at population statistics, there were fewer of us than Chinese, Japanese, and Koreans. So we were mingled with them, and we were thought of as low risk, which was a big mistake. And the reason why I'm here is because of Latha Palanapian, who's in the steering committee, and we worked on a paper together as a scientific statement paper on cardiovascular disease in South Asians because they have such high risk. They die very early. They have high risk for diabetes, low HDL and high LDL cholesterol, and they die early. And it was a call to action for doctors to know that you can't lump Asians together. You have to look at people individually. And you can't even look at everyone, as a population. You have to, when you're a physician or a nurse provider, you need to look at that one person and what their risks are. If they have high LDL, low HDL, they're diabetic, it doesn't matter what they are. They're going to be high risk. It doesn't matter whether they're Korean or Chinese. If they have high LDL and they have high blood pressure and they have low HDL, they're going to be high risk. So we need to be careful in lumping these groups together. The one thing I wanted to add, I know there's been a trust issue with different races, but I wanted to add that I found out that when you talk to South Asians, they actually trust white people more than they trust their own. And I can say that Filipinos probably not to the same extent, but I think that they do trust white people. And it's interesting that these two countries were colonies of British and the Spanish and the Americans. So very interesting cultural differences in that trust issue. The other thing is I found an article that was looking at medication adherence. How do different cultures adhere to medications? And what I found in this study in particular was that whites take medications to feel well and enjoy family life. South Asians take medications to fulfill the will of God and family responsibilities. And Chinese people take medications to avoid pain, illness, and death, but also to obey a healthcare provider. I like the Chinese. They like to obey their healthcare provider. But I think it's, a lot of differences. You have to have a trust no matter what cultures you're dealing with. I think a big barrier is language, of course. The Hispanics are probably our most difficult in terms of language barrier, but the technology has really improved the communication between the physician, the providers, and the patients. We now have these this iPad that we can just press the button, call an interpreter, and you can have an interpreter 24/7. And you can actually see the person, they can see the patient, and it's really great technology, and I've been much, much more successful in communicating with my Hispanic patients. And it's any language, actually, these interpreters. So thank you very much.
Excellent. Wow, you've given us so much richness to consider here. So what I'm going to do now is I'm going to actually tee up a few questions for our panel and have them take it on. But I think they've given us a lot more to go deeper on, and that we really want to spend some time on. But let's start with a consideration. When we think of the population of people that you're here speaking specifically to, are they generally proactive in reaching out for their health? And if so, why? And if not, why? And Anabelle, if I could turn to you or Dr. Volgman first, because you actually brought some of this up.
Great question. I think it's not necessarily a racial or difference in racial or ethnicity. I think it's more of a socioeconomic difference. Wealthy people are really into their health. They want to live longer because they have a great life, and they want to prolong their lives, and they want to be well, and they want to enjoy life. And so they seek prevention. They want to prevent disease. Whereas the not so wealthy people, they're struggling with, trying to make a living and trying to survive, and they don't have time to prevent diseases. They're barely making it. So I'm not sure it's a racial thing. Of course, there's some cultural things, but I think it's what I have. I'm in Chicago, and I have, a whole gamut of patients from the very poor to the very wealthy. And I have a lot of wealthy patients who come to me for prevention. And, I try to encourage my not-so-wealthy patients to do prevention. And it's that trust that they have in me to prevent disease that keeps them coming. But if, and that's deteriorating because of the physician burnout and because of the so many patients that we have to see. Remember that there are many, many more people turning 65 than people being born. And so there are a lot of patients out there who are over 65. They need more health care, and we don't have enough doctors and nurses.
Others on our panel?
I think for American Indians and Alaska Natives, they're not necessarily proactive with regards to their health care for the most part. It comes from several different factors with regards to the impact of federal Indian policy on American Indian and Alaska Natives that developed a trust factor, as mentioned before. And part of that trust factor then becomes the dependency on the government in order to provide the healthcare services for a large majority of American Indian and Alaska Natives, but also the ability to have trust in the providers, especially since over a great part of the history of American Indian and Alaska Native healthcare, many times there were impacts of federal Indian policy on that, including sterilization, including studies on American Indian Alaska Natives without health protections, as well as patient protections, and then other impacts that have occurred. And those were over generations. And because of that, there were definitely challenges in wanting to be proactive for your health care, and the fact that, again, there was a difference between traditional medicine and Western medicine. And that impact, and part of the other federal Indian policy was the inability to be able to practice your own religion, your own medicine, at one point up until the late 1960s, early 1970s. So it's been only recently that American Indians and Alaska Natives have been able to even practice their own traditional medicines as well as their religion in order to help support that. And if you take those away and you make the determinant, that specific health care, which was Western medicine, then it ended up creating a true challenge with regards to American Indian Alaska Natives wanting to be proactive, wanting to be able to get the care they needed, even though it probably was going to be good care at some point. It definitely is a challenge, even to this day, for many American Indian Alaska Natives. With regards to, I don't know if many people have heard recently about the pediatrician that had ended up abusing children. It's not necessarily, cardiovascular disease that we're talking about, but that's an example still today of issues with the traditional Western medicine style and how it impacts American Indians and Alaska Natives in their proactivity for developing and encouraging relationships with their healthcare providers.
Other members on the committee? Go ahead.
So just real quick, to echo a lot of what my colleague already mentioned, when I asked my colleagues across the nation this question, they said that they saw patients, the Latino patients, on both sides of the spectrum. Some of them would come in all the time for mild symptoms. You get those that are coming in really frequently. And then you get the other ones who, as I mentioned, delay care. They delay seeking care. And so we do see those, but again, that depends on the cultural context of the individual and then also the social determinants of health, which we've already addressed. But we are seeing patients on both spectrums. One of the main issues is the individuals that delay care is those who have other priorities, such as working, not having PTO time to be able to go seek health care. And so those are some of those issues that they address, but we do see a variety of them. Those that are proactive, some of them do tend to go seek health care through herbal medicine, through curanderas, and so they will take a proactive approach when it comes to that as well. So thank you.
So I think in the African American community, certainly you have individuals who are limited in their access and their pursuit of healthcare prevention because of their socioeconomic status and the challenges around that. But I think it goes much deeper than that, and I spoke a little bit about this earlier, but there are real cultural issues at play here where health is just not the priority. It hasn't been, and again, it's modeled for what happened, in the generations before you and what your parents did, and that behavior oftentimes can transcend, as I was alluding to earlier, these socioeconomic things. And so if I look at my own circle of friends, I'm fortunate enough to interact with a lot of people from different socioeconomic levels, but probably the healthiest friend I have he's a barber, but he played sports, and so that was his mechanism of being introduced into health, and he's always been very conscious about it. Whereas one of my friends who's a lawyer, one of the top defense attorneys in North Carolina, he has a very fast-paced lifestyle. He eats terrible. He never exercises or works out. He probably doesn't need to use his insurance. He could probably pay cash for it. But health is just not a priority for him. And when I look at his parents, they kind of have a similar profile. And so there's these things that are passed down that you don't learn how to prioritize these things. And then, in some instances, when you become more successful, and again, the priorities and the competing interests become more difficult, if it's not in training you to really be thinking about your health, it doesn't become a problem until you have that heart attack, or that you have a bad headache and you get your blood pressure checked and it's 200 over 120, and you're like, oh crap, like I got to be serious about this. And then again, you be cognizant of it for a while, and then you fall back into those old habits again. And so I think there's an opportunity in many of these communities to just really emphasize health and prevention and being proactive and not reactive, and knowing your numbers and knowing what your problems early on can lead to after years and years of non-control and things of that nature.
Excellent. Well, I'm going to move on to another question, and you're giving us so much richness on a lot of different levels here. One of the things I want to have us tease out more is really understanding what are the barriers and the challenges to actually seeking and navigating care. Now, you've touched on insurance and understanding that. You touched on trust. I heard the word fear. But I wonder if we could take that a little bit further and help us really understand not only what the barriers are, but what you're seeing as some of the solutions. Anyone want to jump in and start on that one?
I guess I'll be volunteer. Here, let's give him the mic.
You look nice to everybody.
Yeah. I'm from the government. I'm here to help you. But, there are various challenges when it comes to barriers, especially for American Indian populations, where the majority of American Indians are on reservations with regards to where they seek health care from the federal service. And many of those reservations are rural in nature. So there definitely is a large rural and frontier rural area that is a concern. And part of that then becomes the context of, how do you develop the right built environment that's going to advance healthcare services? When you have to travel 30 to 60 miles to go see a physician, it becomes a very big challenge in being able to support healthcare advances and even healthcare acknowledgement instead of waiting until the last minute. If you take Alaska, for example, where you might have to fly from a village to the healthcare center, there's those costs that are engaged with regards to getting services for Alaska Natives, especially those that live in the village and not live in an area that has the hospital that's available. So there's definitely impacts with how to get those services available and how to have those impacts. Another barrier is, as mentioned, is the familiarity, or even having the providers and practitioners that are going to see American Indian Alaska Natives with the cultural humility that they would need in order to advance that trust, as well as understanding the population that they're living with in some cases, and being able to support the lifestyle that they want to live, whether it's having a traditional ceremony, maybe they can't take their meds during a traditional ceremony, or maybe the traditional ceremony is 7 nights, and so they're going to be up at night and not during the day. And understanding those different types of impacts that would be able to help make sure that some of those barriers are addressed, and the community aspect of it is important to that. Solutions, obviously there's no way to get over the ruralness. So that whole barrier to that, there is telemedicine and other efforts right now with regards to many rural communities, not just American Indians, Alaska Natives, but rural America as itself. But also more emphasis on how to engage with more cultural humility, I think, is a key part in any aspect of what we do with healthcare in the communities we go in, because for the majority of people, they probably didn't come from those communities, or they left and went back to communities, but after being away for a while, they may not necessarily have that same impact that they used to have. So, being able to address that cultural humility, have those aspects into the trainings throughout our professional schooling, as well as being able to support those communities in the way that they do their traditional practices, I think is key in order to help with some of those issues.
Right.
I just wanted
Yes,
to,
please.
I'm glad you brought up the telemedicine and how we can use that to help people who live very far away from healthcare providers. I actually thought of that as, okay, well, Chicago, we have great transportation, but there are people who still can't get out of their homes because of physical disability or whatever, and telemedicine would be great for them as well. But one thing that I'm glad we're in Washington, D.C., where maybe we can lobby or advocate for changing the rules and how we can care for patients. Because right now, if you are in Illinois, I can only treat patients through telemedicine in Illinois. Only Illinois patients. So even though we're literally a few miles from Indiana and Wisconsin, I can't do telemedicine for patients in Indiana or Wisconsin. So we need to figure out a way where we can nationalize doctors or nurses treating patients across borders. Something that we really need to think about, as we go forward with all the digital health and telemedicine.
Thank you. Any other comments on this question? Yeah, please, go.
So I think there's a few things we can think about here, and there's some best practices out there that we can consider. And so I think it's important to think about reaching the patients kind of where they are. And so I think about it like this. So we need to get into the areas where people pray. So the faith-based organizations are particularly relevant for many cultures, particularly African American culture. I live in North Carolina. I always say if you can't find Jesus, be educated or look good, you have a problem in North Carolina, because we have a lot of barbershops and beauty salons, we got a lot of churches, and we have a lot of educational institutions. But so, and there have been, programs now, the hypertension program that was started by the late Dr. Ron Victor out of UCLA, showed that if we could partner with important places like barbershops, very simple concept. If we could partner with barbers and teach people, black men in particular, to be educated about hypertension and how to control it, and to be able to check it regularly. Everybody gets haircuts. I know in my barbershop, you see the same dudes every week, right, getting their haircut. But so, figuring out how to get people, where they are regularly and make it easier for them to adopt these healthy lifestyles, I think become really important, and to check these things. And really engaging the faith-based organizations, I think, is an opportunity as well, so that as we're learning about our scriptures and the things and how to tithe, my pastor reminds me of that all the time. But as we're learning about these things, like health becomes a part of that as well. And that a big problem in the African American community is that, when people have a health condition, they're stigmatized, they have a personal stigma that they put on themselves, and they're ashamed, and they try to hide it. I remember we did a health fair not long ago, and we had over 300 people that we served through the church. I was feeling really good about it, so we debriefed afterwards. And what the first feedback I got from one of the members was, well, it wasn't private enough. You were discussing my numbers and everybody else could hear. And I'm like, that's the biggest thing you took away from this event, where we checked blood pressures, cholesterol, blood sugars, did Zumba. I was like, you're worried about the privacy, right? And so it just shows you where people are, right? Now I heard her, I wasn't being dismissive, but we've got to get beyond that. Right? We got to help each other. There's strength in community, not kind of hiding in your corner saying, I'm trying to manage my blood pressure all by myself. We've got to move beyond that. And so I think initiatives that really focus on that are important. And the last thing I'll leave you with in terms of a solution-based approach is that there need to be multiple stakeholders involved here. So employers, right? Insurance companies. And so partnerships that bring people together to think about innovative ways to change behavior. And changing behavior is hard. I'm a big carrot or stick person. You're either going to reward them or punish them, but that's how you're going to change their behaviors and have it be sustained. And so a really neat program that the insurance company Duke came up with is they bought all of the healthcare workers Apple Watches. So it's $400 or $500. It's a big investment. But then what they said is that, okay, here's how the program's going to work. If you exercise, so based on your weight, your height, waist, hip circumference, all the important things that we know are relevant, we're gonna have a target goal for you, and the watch calculates all this stuff, right? So if you meet your goal on a monthly basis, then we will pay for this watch. If you don't, you will pay for the watch. But it's cool because they do it on a graded form, right? So like, let's say your calorie goal for the month is, I don't know, 20,000, and you get 10,000. So instead of paying $20 for the watch, you pay 10. And if you get your goal, you pay 0. Man, it's amazing to see how people are like getting steps and they're competitive, and what did you get? How much did you have to pay this month? But I mean, just kind of simple ways. And then so the health system is paying for it, but think about how much money can be saved. And so a little bit of investment up front goes a long way in terms of improving the health of our community and our workforce, and how much money will be saved and days lost from work and things like that. And this is where, people like Lionel and the business folks, really can help us think about innovative ways to think outside the box of how to improve the health of our community. And so I think the time and the urgency is now to really embrace these ideas and just think about things differently than what we have traditionally.
Veronica?
Yes, with the Latino community, I agree. We've done some creative interventions as well, trying to reach the community. And one of the things that the Hispanic nurses did was partner with the American Heart Association to go into beauty salons and train the beauty salon, the cosmetologists there, to screen individuals, to check their blood pressures and have conversations. So we opened up dialogue in those settings, since these individuals go often to beauty salons. And so so that's one way we've done that. The other thing is partnering, as you mentioned, partnering with community-based organizations, the churches, places where they have established trust, and the community trusts these individuals. So even promotoras, there's promotoras. I'm not sure if all of you know what promotoras are, but those are promoters of health. And these are lay people in the community who have been educated on certain health conditions and stuff, and they'll go into the community and educate individuals on, like, say, for instance, heart health, and maybe diabetes, proper way of taking care of their diabetes, eating healthy. And looking at the individuals who have gained trust is really important, since we mentioned the fear factor. And I just wanted to share a story of what one of my colleagues in California shared with me. Is individuals who were illegal they've seen less of them coming in for their care. And the other thing is they were informed that ICE was going to be at Walmart's, checking their status there, so they weren't able to go and get their medications and stuff. So again, we have to look at those issues when it comes to non-adherence. What are those other issues that are keeping them from adhering to the regimen?
Thank you, again, bringing up those important points of trust and fear. What I'd like to do right now, if I could, is turn to the audience and see if you have any questions. We are asking, great. There is a microphone. We are asking if you'd ask your question, go to the mic and ask your question into the mic, because we're recording. Go
There's
ahead.
a microphone up there, Barbara.
Sure, please. We've got a couple of people down
refractory to
front
that.
here. Again, and thank you for being willing to move. But this is good. It's good. It's probably time to stand
get your steps
anyways,
in.
right? If we're looking at our cardiovascular health. Yes,
Yeah.
please go ahead.
Okay. So Dr. Thomas, you made a comment that really sort of resonated with me, and that is many of us today get our health insurance through our employers, or because of prices, we change health insurers frequently, and we change practices. And so our health records disappear with the change of our practice. So how, as we personally, but also as Women Heart, can we educate patients on how best to capture that health record? I mean, today, most of us you've been to your physician and you just assume that record is there. And so I think there's an educational opportunity there to be able to share information on how to gather and save your health records.
Yeah, no, that's an excellent point. And I think the good news is that we're getting better. Like, we're able to communicate with healthcare systems across the country now, more so than we have ever before. I mean, with all the challenges we've had with the VA medical system, that's one thing that they have done exceedingly well, is to have a healthcare information exchange where I could be sitting in Durham and somebody was seen at the Washington State VA, and literally I could pull up their records in minutes. And so I think that's an opportunity to learn. And with Epic, and as we begin to centralize, and this is where capitalism, I think, is a good thing, when we begin to centralize and share medical records, I think we're going to make some progress there. But again, as I mentioned, I'm a practical person. Life is hard. I'm trying to make it simple. And so I tell patients, I'm like, get you a little notebook. Bring it with you to a visit. Like, you see these people with planners, and planners are pretty cheap. I gave them away to my staff as a gift, so I know they're pretty cheap. So get a planner and literally just write this down and keep a record of it and take it with you when you go to the doctor. Because you can't remember all this. I can't remember all this stuff. And so, you just pull it out. And I had a patient who did exactly that. And I was like, you on this medication? Like, when was it started? And they were like, it was started September 8th of 2016. And I'm like, can I just like clone you? But I think there's simple ways that we can help patients think about this. And it's one more thing for us to do, but man, of all the things I do, and I do some pretty complicated procedures, sometimes just having these kind of candid conversations with my patients to say, you know what, keep track of your record. Don't wait for anybody else to do it. It's your body. It's not my body. It's not who you saw before's body. It's your body. Keep a record of it. And just in that way, when questions come up or we're unsure about things, I mean, this can reduce medication errors, all these different things, because when people don't know what they're on or it's entered incorrectly, like, you have your stuff here and you can say, no, this is what I'm taking, this is how long I've been taking it. And so I think very simple solutions like that can really go a long way.
Great, thank you. We only have a few more minutes for the panel, and I want to make sure we get our audience questions, so please go ahead.
Kathleen Pinto with Hispanic Therapeutics. So thank you all, first of all, for all of your great presentations and your stories. More of comments than questions. The system that we deal with disparities in healthcare access is multifactorial, and it's very fractionated. I think that, you talk about multiple stakeholders and things like that. I ran a campus community access program for diabetes and hypertension in the late 80s for Blacks and Hispanics. And it was amazing to me how when you empower people, and they became empowered when they reached the healthcare system, there was an anemic tendency towards the bidirectional dialogue that occurred. One of the things I think we really forget is the power of children. When I grew up, there were presidential awards based on physical fitness and things like that. They don't have that anymore. They don't have access to arts. And those two things together really make an individual embrace their self-worth, their being, and they bring that back home to their families. Great. So something to think about.
Thank you, and thank you for your comments and the wisdom and experience you bring to today.
Thanks to the panel. It was a really enlightening talk. I'm Selena Goy with Women Heart. And one question is talking about what we're doing at Women Heart, but also to combine my previous life where I ran something called the Global Alliance for Chronic Diseases, where we funded implementation research. Now, the vast majority of what you're talking about or described today is really the ideal sort of interventions where you would study that in an implementation research program. So my question to you is, a lot of the research that you all are involved with are clinical and medical and really sort of on, let's say, the higher end, let's say, of research, and you're talking about RCTs. But if you want to go to where the patients are, you need a whole different kind of research. You need a whole different kind of methodology. So to what extent are you all involved in that? Or to what extent are you working with, let's say, public health professionals who, that's their bread and butter? Thanks.
Dr. Clelland, do you want to speak to that coming from the CDC perspectives? I know this is an area of some of your work.
Yeah, I think that's a really great perspective with regards to where public health plays a role in cardiovascular risk reduction and being able to promote healthy lifestyles. And going back to the previous speaker or previous question or comment by the other person, is bringing back those areas in communities that really really impart that population component of public health, and especially in communities that, whether you are in a large faith-based community or a traditional community that has various aspects to it. So right now, the CDC is doing an exhibit of public health in Indian country, and it's called Changing Winds. Part of that is looking at what are those public health approaches that is organic to communities that they're using to advance their own public health and thus disease prevention. Two examples that we're highlighting is the use of cradle boards. And cradle boards are really important to American Indian communities because not only does it promote that connectedness between culture and tradition, but it also provides those techniques of, raising a child and being disciplined and making sure that you're always attentive. And then those aspects of swaddling and things like that that really, are important for that healthy being of a child going up. Another one is a community group that was looking at tobacco, and obviously, tobacco prevention is really important in decreasing the risk of cardiovascular disease. But there is tobacco use within Indian country that's used for religious and ceremonial purposes. So they worked on developing a program not only to do cardiovascular risk reduction because of tobacco prevention, but also to bring back the traditional and cultural aspects of using tobacco wisely within those cultures, and then training and teaching the students how to respect tobacco for its medicinal purposes, traditional tobacco, while also using that prevention effort, especially for cardiovascular risk with a cigarette prevention program. So there are many aspects to that, and these two areas were all organically done within Indian communities, and then were highlighted through the CDC in order to show how that public health impact and approach can help in disease prevention, especially with cardiovascular risk.
Just a quick comment. I know we're running out of time, but just to answer your question, the American Heart Association is doing some grants. They funded some studies to look at adherence to stroke prevention with atrial fibrillation. They gave $10 million to 2 universities to study shared decision-making and how much it impacts whether patients actually take warfarin or the novel anticoagulants.
Right, thanks for bringing that attention. Our final question from the audience for this part of the
Good
day.
afternoon. My comment and question is this. Looking at the title you have up there, what are the barriers and challenges? Now, I'm a Washingtonian, and I was born in Ward 7, which we call East of the River. When I was younger, we had 2 of the best hospitals in the country, DC General, then Kafers, then it changed to Greater Southeast. What we're dealing with in this area is politics. We have United Medical Center where they basically stripped the hospital down to a clinic. But I hear us saying here that we have a lot of programs for cardiovascular. Why can't MedStar come and put a satellite center in the areas where it's affected the most? Why can't we have these same conferences over in the areas that it's affected the most? When we don't have these conferences in the area where it's affected the most, you cannot help a soul. Your statistics are no good. And I've always been an advocate of it. I'm a certified tobacco treatment specialist. So I was listening to what the captain had said a little bit earlier. I basically come to it from a cognitive processing therapy approach. Most people are dealing with stress. Stress is the #1 killer because of the way they react to it. And trying to get them to see that you may not have the best, but you need to go out and research to find the best, because you are the best. They've been beaten down so bad in the community that they don't want to travel here to get help. They don't want to come over there. They want to stay where they are. And I said, you got to go. You got to leave your comfort zone. And it's trying to help people change the mindset like the one doctor said, change your mindset. We did the Biggest Loser Challenge at the Masonic Temple, Prince Hall Mason, and I entered it. And I told him, I said, look, I'm having a rough time because Thanksgiving, that's my time. And if you let people see that you're a human and not just a doctor, that you still have faults, you'll be surprised how people will change. Like I said, just changing their mindset.
So your points are so well taken. Thank you. I think that actually is a really nice capstone to our panel. We're going to have more time for audience questions and comments as we go on throughout the day. I want to take this time to thank our really amazing panel. Thank you. Thank you.